Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions. Also, a big thanks to Justin Kugel for his video editing, support, and creative contributions.
Thank you for joining us on 10 Clinical Minutes. We've been learning so much through this whole process, and we are so glad to have you learning alongside with us. Now, let's get to the episode.
Good morning, everyone. Welcome to 10 Clinical Minutes. We are glad to have you back for a discussion this morning about aspiration pneumonia, which can be a misleading entity. So first off, start with some definitions. This is basically airway weeds, something that gets in a place where you don't want it. If you have grass in the wrong place, it becomes a weed. If you have a weed in the right place, it becomes grass. And so it's really, the definition is the entry of unwanted foreign matter by suction, thus the name aspiration, into the airways. Epidemiology, about 5 to 15% of community-acquired pneumonias are related to what will be termed aspiration pneumonia, 5 to 15% of hospitalized as well. And then interestingly, post-cardiac arrest, there's about a 65% risk of developing a pneumonia secondary to aspiration in 3 days. And that a lot of times is due to the chest compressions that then force gastric contents back up and increase the risk for aspiration while somebody is unconscious. Normally, it's an acute process, acute to subacute, developing within hours to days after the aspiration event. And then here are just some risk factors. You have an impaired cough, impaired swallowing, or retrograde GI contents. Anything that can cause any one of these three, reducing someone's ability to cough, components that enter the airway back up and out, impairing the swallowing reflex, increasing the risk and likelihood of aspirating contents, or anything that increases likelihood of having retrograde GI contents. So stuff being unable to come back out, increased likelihood of it going down the wrong pipe, or increased likelihood of it coming up and then going back down. Anything that can cause one of those risks is going to increase your risk of aspiration, and those are detailed out there. So there are a couple of affiliated clinical syndromes that people reference whenever they describe aspiration pneumonia. 2 of them are acute, chemical pneumonitis and mechanical obstruction. And then one, aspiration, is more insidious with the hours to days onset. Chemical pneumonitis is due to the ingestion of gastric acid that's at a low pH. Thus, it is sterile and doesn't require antibiotic treatment. You get an acute respiratory distress type syndrome. It develops rapidly and quick in onset, and you treat it just like you would treat acute respiratory distress with positive pressure ventilation, IV fluids, and then suctioning out the aspirated contents from the trachea. Mechanical obstruction, you aspirate contents, and those contents actually end up causing shortness of breath due to the airway being occluded. You can also get infections from this because you then have the gastric contents present, but then also an area where there's no clearance of foreign material, and thus antibiotics are indicated for mechanical obstruction. We're going to spend most of our time today on aspiration pneumonia, the middle entity, which produces sputum and is treated with antibiotics, and is what most people think they're referencing whenever they use the term. But from a syndrome perspective, it would be included with these chemical pneumonitis and mechanical obstruction. So what is aspiration pneumonia? Technically speaking, all pneumonias are aspirations. It's well recognized that community-acquired pneumonia as a result of aspiration, but that's micro. And so you might hear someone on the rounds talk about how, oh, don't you know that all aspirations or all pneumonias are actually aspirations. And that's true, but when someone refers to aspiration pneumonia, what they're referring to is a macro aspiration of oropharyngeal or gastric contents. The pH is going to be greater than 2.5. Below that, it's going to be sterile and trigger chemical pneumonitis. So whenever we're going to use the term aspiration pneumonia, we're referring to that macro aspiration of gastric contents, or that are either oropharyngeal on their way down or gastric on their way back up. These are some radiographic findings on X-ray and CT scan. In order to make the diagnosis of aspiration pneumonia, you really just have to have the suspicious history, a confirming exam, and chest X-ray findings, or CT findings if you obtain that instead. You don't have to have a positive sputum culture. You don't have to have a positive source. These 3 things alone will give you the diagnosis. How do you treat it? Historically, anaerobes predominated, and so the treatment would have been focused around that, and you would have had these purulent foul-smelling sputums. Now it's more of an aerobe disease. 30% of abscesses, however, are anaerobes. But if it's only aspiration pneumonia without abscess, generating E. coli, Klebsiella, or Pseudomonas aeruginosa, those can form abscesses, but it's not the most common presentation of it. And then if you get a good clinical response, you only need to treat for 5 to 7 days. Now, if you have an anaerobe and an empyema, an abscess, the most recent guidelines from the American Thoracic Surgery would be that you add clindamycin. Other than that, you start with ampicillin sulbactam for both community-acquired and hospital-acquired, and then you progress as sensitivities or as the risk of resistance increases, as detailed in the table going off to the right. But probably the biggest takeaway from this slide is that you don't have to cover for anaerobes right away, and you can actually just kind of leave it with the ampicillin 5 to 7 days for your treatment course. So how do we prevent aspiration? There are things that are recommended. There are things that are borderline and maybe helpful but don't have good evidence. And there are things that are not recommended that are either ineffective or harmful. So recommended pre-op fasting, clear liquids that really prevents chemical pneumonitis during procedures. Given antibiotics for 24 hours after emergency intubation. That's due to the increased risk of aspiration, kind of similar to the risk that you accrue whenever you have a post-cardiac arrest. Putting someone in semi-recumbent position, sitting them up while they eat, giving them oral feedings rather than NG feedings, and then thickening the diet is all helpful. Borderline, swallowing evals after a stroke and after an extubation, not necessarily indicated, not necessarily helpful. May catch people with pre-existing dysphagia, but not likely to be recommended unless you witness an aspiration event. So those can be helpful, but don't necessarily. Dental hygiene, sometimes they'll clean the mouth beforehand. It's not proven to have any evidence. It may help anyways. And then the ACE inhibitor piece, that actually increases the cough reflex. And so it has been shown to be effective in certain patient populations, but in others it is not. And then we get to the ineffective. Doing swallowing exercises with physical therapy after a stroke does not actually, hasn't been shown to prevent it. Oral chlorhexidine during a procedure has not been shown to improve the bacteria within the oral cavity, and thus hasn't been shown to prevent it. And then harmful, laying someone down while they eat. Using any form of enteral feedings, whether that is a PEG tube, an NG tube, a J tube, or a post-full tube, they all increase the likelihood of having an aspiration event and are actually harmful. And then giving somebody a puree diet or thin liquid is obviously going to increase the risk of aspiration. So key points, true aspiration pneumonia is a result of macroaspiration. Historically it was anaerobes, now it's aerobes more than anaerobes. Treat with ampicillin 5 to 7 days and only add the clinda if you have empyema or an abscess. And then consider your risk factors in a patient. Do they have an impaired cough? Do they have impaired consciousness? Or do they have retrograde GI contents? If they have any of those risk factors, aspiration goes up on the list, then you'd be more clinically suspicious of it being the entity causing your patient's clinical symptoms. Here are my references. If you like the links to them, you can get a hold of me and I can get these to you. You can contact us at info@decodingdx.com or through our website. Thanks so much. Have a great day.